Pleasant day to all of you future RMTs. Welcome to our virtual classroom. And in today's lecture, what we are going to discuss is all about cerebrospinal fluid. Okay? So for our learning outcomes, we have to discuss the three major functions of cerebrospinal fluid, differentiate CSF specimen caused by intracranial hemorrhage and traumatic top, and to discuss the etiology, pathogenesis, and laboratory tests to detect meningitis. To start with, let us have first the basic anatomy and physiology of our spinal cord or central nervous system. Take note, guys, that our central nervous system is composed of our spinal cord, and the spinal cord itself has what we call the meninges. Okay, this meninges is the brain and the spinal cord, and meninges is divided into three layers. We have the dura mater, we have the arachnoid, and we have the pia mater. Now take note that dura mater is known to be the outer layer or known to be the hard matter, okay, and lines the skull and the vertebral column or vertebral canal. While for our arachnoid, it is the filamentous inner membrane of the spinal column or spinal cord, and we have what we call the subarachnoid. And in the subarachnoid space, it is where or the canal where the CSF flows. Take note that the arachnoid or subarachnoid in particular is the canal where our CSF flows. Okay, and it is often referred as spider web like. No, it is often referred as the spider web like. While for our pia mater, which is the innermost layer, no, and that is the what you call this, that lines the surface of the brain and the spinal cord. So basically, these three uh, parts or layers of the meninges is important, no, for you to remember in order for us to know the functions of our spinal cord. Okay? Now, aside from that, we have what we call the choroid plexus. It's a specific part of the brain that produces the CSF via selective filtration. Now, take note, our arachnoid or subarachnoid in particular is the canal where the CSF flows, and it is our choroid plexus which is the one responsible for the production of our CSF via selective filtration. And the rate of CSF production is seen at 20 ml per hour. No, is the rate of CSF absorption, and at the same time the rate of CSF reabsorption. Again, take note, subarachnoid space or subarachnoid is the canal where our CSF flows. Choroid plexus is the one responsible for the production of our cerebrospinal fluid via selective filtration at a rate of 20 milliliters per hour, and that is also responsible for the reabsorption and production. Okay, aside from the capability to produce, it is also capable of reabsorbing our CSF, while our arachnoid villi is the one responsible for the reabsorption alone of our CSF. Next, there is an important part of our CSF which is named as the BBB, or also known as the blood-brain barrier. Okay, what is the purpose of this blood-brain barrier? That's actually one of the most important factors or one of the most important parts of our uh, central nervous system or our brain, no, the spinal column. Why? Because this blood-brain barrier protects our brain and cautions, no, it gives cautions to our brain, no, and aside from that, blood-brain barrier, no, protects the brain from the chemicals and other substances that might get entry into the brain tissue, and it can cause harm to the tissue, no, to our brain tissues, as well as blood-brain barrier uh, no, doesn't allow WBC and proteins and other chemicals to enter into our central nervous system or in our CSF. Now, let's say for example that this blood-brain barrier or BBB is destroyed or there is a disruption in our blood-brain barrier. What will happen is the WBC proteins and other chemicals such as toxins may enter or may pass through our blood-brain barrier or our CSF, then it might cause an abnormality. Let's say, for example, increase in protein, no, that should not be seen in the CSF. Let's say, for example, albumin. No? So again, these are the most important parts of our central nervous system, particularly the brain, that I want you to remember in order for you to correlate the results or what is the condition of the patients with these laboratory findings. Okay. Now, what are the major functions of the CSF? Okay, the major functions of the CSF. Number one, we have three major functions of CSF. But out of these three major functions, the most or the superior, no, function of our CSF is number one. It supplies nutrients to the central nervous system. Okay, it supplies nutrients to our central nervous system. Okay, and like we have said, no, the choroid plexus is the one responsible for the production and reabsorption of our CSF, and okay, our CSF is also responsible for what? It is also responsible for the removal of the metabolic waste, no? Now, like our, di ba sabi natin, kidney is the one responsible for doing that. But aside from that, CSF is also capable of removing metabolic waste. And take note that our CSF is the one that produces mechanical barrier to caution the brain and the spinal cord against trauma. Kaya, let's say for example, you have a little injury or little nauntog ka, no? Hindi naman agad-agad makakameron ka ng dementia or loss of consciousness because we have the CSF that cautions our brain as well as our spinal cord against trauma. Now, unlike urine or unlike stool or unlike blood, no, unlike urine, no, as we discussed into the part of the urinalysis, urine is very easy to collect. You just have to go to the comfort room and then let you urinate. Then after that, you collect it, no, and you have already your urine sample. And if there is and if there are discrepancies or results that are questionable, it is easy for you to ask the patients to recollect for blood sample or for urine sample rather. Well, of course, for blood it's also the same thing. Yun nga lang, for blood, you have to perform manufacture once again. You have to extract blood. But what if for CSF? How are we going to collect sample for CSF? Are we going to collect CSF in our school? No, because there are only certain practitioner or specific practitioner or medical practitioner who can isolate or who can perform or who can collect our CSF. Okay? Take note, guys, that the CSF is collected via lumbar puncture. Okay? Between the third, the fourth, or the fifth lumbar vertebrae. So, ibig sabihin, it requires enough skills to perform aspiration of CSF. If phlebotomy requires skills, no, and techniques in obtaining the blood sample, well, definitely for lumbar puncture, the same thing is to be followed. But not as simple as phlebotomy procedure ang gagawin mo dito. Because take note, we as a medical technologist, even though that we are studying and we are going to discuss on how you are going to do this, on where to collect the CSF, take note that we are not allowed to perform lumbar puncture because it is only the medical doctor who can collect lumbar or who can perform lumbar puncture, or in other words, who can collect CSF. Why? Because it is invasive procedure. No, the doctor will ask the patient to lie on a supine position. No, the doctor will administer anesthesia, because remember, it is a you're going to puncture, you're going to bore the lumbar vertebrae. Oh, buto yan, no? And then you're going to aspirate the CSF from that. Okay, take note that you can only collect up to 20 ml. Okay, you can only collect up to 20 ml CSF. Why? Because we have a specific amount of CSF. Okay, so later we are going to discuss what is the total volume of CSF in adults and in neonates. Magkaiba po yan. Okay, that's why I want you to remember lumbar puncture is performed by medical doctor, no, at between the third, the fourth, or the fifth lumbar vertebrae, and they can only collect up to 20 ml, no, up to 20 ml, not more than 20 ml of CSF. Okay. Now, what are the considerations to remember in collecting or in performing lumbar puncture? Number one is measuring the intracranial pressure. Now, what is the purpose? Why the doctors, or why do we have to indicate the intracranial pressure? Because if there is an increase in intracranial pressure, meaning to say, once you bore, or once you insert the needle to aspirate, the flow of the CSF in the central nervous system or in the spinal cord going to the brain and vice versa ay mabilis because of high pressure. The flow is increased. Therefore, if you will insert a needle to bore this lumbar vertebrae and to collect and aspirate the CSF, the flow of the CSF going out is mabilis. Okay, what will be the problem? The problem might be there will be a drainage of the CSF in the circulation. Next, another thing to consider is definitely, since that you are going to collect CSF in the lumbar vertebrae or in the vertebrae, a careful technique is to be followed to prevent infections or neural tube damage. Okay? Infection. It is prone to infection if you will not perform it in using aseptic technique. Bakit prone ng infection? Okay? Mayroon ng gain of entry, mayroon ng port of entry ang mga microorganisms and bacteria that can cause meningitis, that can cause inflammation in our meninges. Okay? So again, remember, you have to consider first, no, the intracranial pressure, as well as to perform it carefully, no, to eliminate the chances of producing infections or neural tissue damage. Now, like what I've said in a previous slide, we can collect up to 20 ml of CSF. Now, I want you to know and I want you to remember that we are going to collect CSF into 4 different tubes, 4 separate tubes. You are going to collect CSF into a plain tube. Okay? You are going to collect CSF into a plain tube, and it should be labeled as tube 1, tube 2, tube 3, and tube 4. Now, what is the purpose of putting labels? What is the purpose of indicating that this is the tube 1, this is the tube 2, this is the tube 3, and this is the tube 4? Because each tube or each collection tube of the CSF has a designated section where it will go. Let's say, for example, let's say for this one, tube number 1. Tube number 1 is designated for chemistry or serology. Tube number 2 is designated for microbiology. Tube number 3 is designated for hematology, and tube number 4 is designated for cytology or for reserve. Now, you might ask or you might wonder, why do we have to assign tubes in particular sections? Why do we need to have tube number 3 for hematology, tube number 2 for microbiology, and tube number 1 for chemistry? Does it affects, or does it has a clinical significance? Why do we have to do that? Yes, of course. It has a clinical significance, and you have to remember that you should follow the correct sequence of obtaining the CSF sample, and you should take note alin po dito yung nauna. Therefore, pre-labeling of tubes is not recommended. A labeling of tubes 1, 2, and 1, 2, 3, and 4 should be done right after the collection. Okay? Why? Why pre-labeling is not possible or not recommended? Because if you will pre-label and supposedly you will have the first tube and you unfortunately give the tube number 2, no, it will have an interference. Or ano nga pong bang interference ang mangyayari? Take note guys that tube number 1 is designated for chemistry because tube number 1 or under chemistry you will just detect the protein, the glucose, the lactate level, or even the IgG level of our CSF. And no and if there is what we call intracranial hemorrhage, no, the blood will not have an effect on that. Okay, why tube number 2 is designated for microbiology section? Because the external contamination or external contaminants that can be present in the skin will be, or in the needle itself, no, will be passed through to tube number 1. So ibig sabihin, less no less po yung mga possibility na magkameron ng external contamination in tube number 2. And why tube number 3 is designated for hematology? Because of it contains less tissue fluids that can cause interference in the hematology for the count of RBC and WBC as well. Now, let's say for example that there is an intracranial hemorrhage, so ibig sabihin, there is an equal distribution of the blood. Now, what if there is a traumatic top? No, traumatic top includes, or traumatic top is caused by damage, no, accidental damage during the puncture. So, ibig sabihin, there will be an increased blood, no, from tube number 1 going to tube number 2. So, pababa. Mataas yung concentration ng blood sa tube number 1, ay lessen sa tube number 2, and more lessen or mas less mababa in tube number 3. That's why it is recommended that tube number 3 is for hematology. Now, what if we cannot perform the CSF analysis immediately? No, we can preserve it. CSF, tube number 1 for chemistry, can be preserved at frozen or freezing temperature. Tube number 2 for microbiology can be preserved at room temperature, and tube number 3 for hematology can be preserved at refrigerated temperature. Now, I want you to take note that CSF analysis must be done on stop basis. Why? Because the cells may disintegrate or may destroyed upon standing into a different conditions or time. However, since given a chance or given a condition that we cannot perform the CSF sample immediately, then we have to preserve it. Meaning to say, no, these preservation techniques or environmental preservation must be followed to maintain the integrity of our CSF sample. Okay, take note again, even though that you are going to collect 4 tubes, no, it doesn't mean that each tube may contain 20 ml. No, the maximum amount or the maximum volume of CSF that you can collect is 20 ml. It doesn't mean that you have to collect 20 ml of each tube, because if you are going to collect 20 ml for 4 tubes, that accounts for almost 80 ml already. No? And if you are going to aspirate and you are going to collect 80 ml, magkakameron ng drainage in our CSF, because a normal adult obtain or has a 90 to 150 ml of total CSF volume. Now, how about for neonates? For neonates, you only have 10 to 60 ml and you're going to collect 80 ml. For God's sake, ano naman yung gagawin mo dun sa bata? Okay? So, ibig sabihin, this 20 ml is the maximum capacity for the maximum capacity na hindi ibig sabihin each tube. Therefore, we can say that if we have a capacity of 20 ml as per collection, and we are going to collect 4 tubes, no, we can say that we can collect 5 ml per tubes. Okay, 5 ml per tubes. Now, given the chance or given the fact that I guess I have here. Okay, now given the fact or given the chance that there are inappropriate amount or insufficient amount of CSF to have, no? Insufficient amount of CSF ang na-collect natin. So we can have the tube number 1, tube number 2, tube number 3, and number 4 as tube number 4. Now the question is, no, how are we going to test the CSF sample? Where or what particular section will do the analysis first? Okay, take note, guys. No, take note. Take note of this. If you only have one tube, for CSF, the first section that you are going to, or the first section to use the sample is the microbiology section. Okay, the first sample, no, the first sample or the first section to use the sample is the microbiology section, to be followed by chemistry, to be followed by hematology. Okay, the first one is microbiology, to be followed by chemistry, to be followed by hematology. Okay, now it is not unusual for cell counts requested to be performed for tubes number 1 and tubes number 4 to check for the cellular contamination by the puncture. Okay, so usually tube number 4 is used for reserve or for cytology analysis. Okay, now I've mentioned a while ago that we have traumatic tap, no, that we have intracranial hemorrhage. We're going to discuss that after this slide, but for the purpose of this slide, we're going to discuss the normal or the CSF appearance. Okay, normally CSF is considered or appeared as a crystal clear, no? Crystal clear ang appearance ng ating CSF. Okay, now CSF appears turbid, hazy, milky, or cloudy. It is clinically significant because it means that there is an increased WBC of greater than 200 cells per microliter and increase of RBC of greater than 400 cells per microliter. Turbid, milky, and hazy CSF also suggests increase in lipids, proteins, and as well as the possibility of having a bacterial contamination or microorganisms, or increase in number of microorganisms. Now, what if the CSF appears xanthochromatic? What do we mean by xanthochromatic? Xanthochromatic CSF may appear as pink, yellow, or orange depending on the severity of the hemoglobin degradation products. Okay, again, xanthochromatic CSF is due to hemoglobin degradation products, and xanthochromatic CSF may appear as pink, yellow, or orange. Now, it will appear as pink if there is a slightly amount of oxyhemoglobin in the CSF. It will appear as yellow if there is a oxyhemoglobin to indirect bilirubin. Okay? And it will appear as orange if there is an heavy hemolysis. Now, other causes of xanthochromatic CSF includes increase in carotene, which appears orange CSF, melanin, no, and protein of greater than 150 milligrams per deciliter, and due to the effects of rifampin, a drug, no, that causes reddish discoloration in the body fluids. Now, aside from that, CSF may be bloody, and bloody CSF may due to increased amount of RBC. Now, increased amount of RBC may be possibly due to two reasons. What are these two reasons? There is a traumatic tap and what we call intracranial hemorrhage. Now, how are we going to differentiate traumatic tap from intracranial hemorrhage? Now, when we said traumatic tap, no, there is a problem or there is a injury, no, a trauma while performing the lumbar puncture, or let's say for example a vein was damaged or the vein was hit during the procedure, which means there will be an increased amount of blood. Now, why for intracranial hemorrhage? No, for intracranial hemorrhage, there is a hemorrhage within the a brain already, okay, which will give us an equal distribution of the blood in tubes number 1, 2, and 3. Why? Because the origin of the hemorrhage or the origin of increased amount of RBC is within or inside the cranial, no, inside the cranial cavity or inside the spinal cord. Now, for traumatic tap, accidental injury, no, during the lumbar puncture. That's why, like what I've told you a while ago, no, that's why tube number 3 is designated for hematology because it will has the lesser number of RBC from a traumatic tap. Okay? So how are we going to differentiate traumatic tap using the blood distribution of tube numbers 1, 2, and 3? If the tubes 1 and 2, 1, 2, and 3, or the red color lights or naglighten siya, ibig sabihin there is a traumatic tap. But if the CSF color or the red color of the CSF is uniform among the 3 tubes, then it means that there is a intracranial hemorrhage. But aside from that, what are the other tests or the other parameters that can be used not to differentiate traumatic tap from intracranial hemorrhage? Well, of course, we have the clot formation. A clot formation is positive for traumatic tap because of the presence of what we call plasma fibrinogen that is seen in the blood from a traumatic injury. Well, for intracranial hemorrhage, no, it is negative for clot formation because our CSF does not contain fibrinogen. Another parameter that can be useful is for the supernatant. When you centrifuge our CSF, no, and there is a clear supernatant, then it means that it is a traumatic tap. However, if there is a xanthochromatic, no, red, pink, or orange in our CSF after the centrifugation, then it means that is a intracranial hemorrhage or cranial hemorrhage. Aside from supernatant, aside from clot formation and blood distribution, we also have here our erythrophages. Now, take note, guys, when we said erythrophages, these are macrophages with ingested RBC, and our traumatic tap does not contain erythrophages. Okay? While our intracranial hemorrhage is positive for erythrophages. And last but not the least is our D-dimer test. Okay, traumatic tap is negative for D-dimer test, and intracranial hemorrhage is positive for D-dimer test. Okay, so these are the appearance of our what you call this? Appearance of our CSF. Okay, tube or illustration A, no, shows a normal CSF. Okay, it shows a normal color of our CSF. Okay, tube number 2 shows a intracranial hemorrhage, no, equal distribution of our blood in the tube. Picture letter C shows what? Xanthochromatic CSF, a yellowish, no? And tube number, letter D rather, shows a traumatic tap, an even distribution of red color. Okay? Now, aside from that, our CSF may appear as oily, and CSF as oily is clinically significant or correlated at or with radiographic contrast media contamination. Okay? Clotted because of protein and clotting factors, and our meningitis, no? We also have what we call what you call this? Freund syndrome, as well as the blockage of the CSF. Now, if our CSF appears as pellicle, no, it means that there is a tubercular meningitis. Okay, take note, guys. If our CSF appears as pellicle, no, it means that there is what we call the presence of tubercular meningitis. Now, I want you to take note of this. What do we mean by Freund syndrome? Okay, Freund syndrome is a coexistence of xanthochromia and high level of proteins, okay, and marked coagulation of CSF. That's why our CSF appears as clotted in Freund's syndrome. Okay, now it is caused by meningeal irritation during spinal meningitis and the CSF flows blockage by a tumor mass or abscess. Okay, that's why the CSF of a patient with Freund syndrome appears clotted. Now, like what I've said a while ago, no, the CSF analysis should be done on a stat basis. Okay? Should be done on stat basis. Why? Because WBC and RBC begins to lyse within an hour after the collection. And of course, 40% of our WBC disintegrates within 2 hours. So, ibig sabihin, there will be a positive or false increase, a false decrease rather, in our WBC and our RBC if we are not going to count it or perform it immediately. Now, there are considerations to considerations to consider, no? Nakakatawa yun. Considerations to consider. What are our considerations? Number one is WBC count most frequent. Why? Why is it WBC count is more frequent than RBC count? Because WBC count suggests the presence of infection, while RBC count suggests intracranial hemorrhage. And you have to consider and you have to think or you have to consider the possibility that the CSF appears blood because of traumatic tap. Okay, usually RBC count is performed using RBC or using traumatic RBC is usually count if there is a traumatic tap. Okay? Now, if we are going to count our WBC, now using our Neubauer counting chamber, no, I assume that you all know what is a Neubauer counting chamber as this was discussed to you in your hematology. Okay, so we are going to use the the 9 squares of our Neubauer counting chamber, no, for our WBC count. Okay, so for neonates, the WBC is 0 to 30 per microliters, and for adults is 0 to 50 WBC per UL. Now, I want you to take note of this one. No, this is the formula to get our CSF WBC count. Cells counted times dilution factor divided by area times depth. Okay. Usually, the depth of our Neubauer counting chamber, if you're going to use the WBC squares, that is 0.1. Okay, the area is the number of the squares where you count the WBC. Okay? Now, we have dilutions, no? Kagaya ng kung sinabi ko sa inyo, in computing or in assessing or computing the CSF count, the cells counted times dilution factor over area times depth. That's why we have our dilution factors. Now, let's say, for example, our CSF is clear. No, it doesn't mean or it does not require dilution. Now, sir, how are we going to multiply it? How are we going to get the number of CSF if we don't have dilution? No, you can count it or you can multiply it by 10 as the standard dilution. Okay? Now, slightly hazy is 1:10, hazy 1:20, slightly cloudy is 1:100 rather, cloudy or slightly bloody is 1:200, and then bloody or turbid is 1:10,000. Now, I want you to take note and I want you to remember these dilution factors. No? Now, what are the other important things to consider? Now, we have what we call WBC diluting fluid. no? And that is our acetic acid. Now, the purpose of using 3% acetic acid is to lyse RBC if we are going to count WBC. And the purpose of methylene blue is to give color to our WBC. And aside from giving color, it will also help us to differentiate and identify what are the different WBC present in the CSF. Now, I want you to take note of this one. Okay? For RBC count, note it is done only in cases of traumatic top, and there is a way to correct WBC count and total protein concentration. Take note of this. Every one missed WBC count, no, 700 RBC is seen. Less than 8 milligrams per deciliter total protein concentration for every 10,000 RBC per UL according to Henry's, and minus 1 milligram per deciliter for total protein concentration for every 1,200 RBCs per microliter. That is according to Strasser. Okay, so take note the correction for WBC count. Okay, so for CSF differential count, it is performed in a stained smear. It is not performed in a Neubauer counting chamber. No, it is performed using a stained smear. Okay, usually we are using hematological stains such as GEMSA, no, as our stain. Now, specimen should be concentrated before smearing by using of the following methods. We have cytocentrifugation, we have centrifugation, we have sedimentation, and we have filtration. Now, of all four methods, no, cytocentrifugation is the best. Okay? In cytocentrifugation, fluids is added into a conical chamber. Cells are forced into a monoclonal or monolayer within 6 millimeters diameter circle on a slide, and addition of albumin. And the purpose of addition of albumin is to increases cell yield recovery and decreases cell distortion. Okay, so this is the cytocentrifugation. Now, what are the cells that can be found in the CSF? Now, the predominant cells in the CSF is lymphocytes and monocytes. Now, I want you to take note of that. The predominant cells, for CSF is lymphocytes and monocytes. And occasionally, we have neutrophils. Now, take note that neutrophils is sometimes, or if there is an increased amount of neutrophils, it suggests what? This suggests bacterial infection or bacterial meningitis. Okay? Now, take note, guys, that in adults, since lymphocytes and monocytes is our natural cells or predominant cells, we have what we call the 70-30 ratio, wherein 70% of the cells in the WBC in the CSF of an adult is account for lymphocytes, and 30% of that accounts for our monocytes. Well, of course, there is a inverse ratio for neonates, because for neonates, no, the most or the predominant cells is lymphocytes, no. So we can say that 80% of the cells is lymphocytes, and the remaining is our 80% is monocytes. 80% is monocytes, and the remaining 20% accounts for our lymphocytes. That is for neonates. For adults, 70-30, 70 lymphocytes, 30 monocytes. For neonates, 80% monocytes. Now, we have what we call phagocytosis. And what do we mean by the word phagocytosis? When we said phagocytosis, that is an abnormal condition wherein there is a increased number of normal cells in the CSF. Meaning to say, yeah, it is acceptable that lymphocytes and monocytes are predominant, but if there are increased numbers of lymphocytes and monocytes, that is what we call phagocytosis. Okay? Now, if there is an increased amount of lymphocytes, no, above its normal range or above its normal number, then it means or it suggests that there is a viral infection or simply viral meningitis. Well, for neutrophils, no, if there is an increased amount of neutrophils, again, it suggests bacterial meningitis. Okay? So we have here the predominant cells or the cells that can be seen in our CSF. And number one, since lymphocytes and monocytes is the predominant cells, take note that if the number is increased, no, if the number is within the range, then it is considered normal. But if there is an increased amount of lymphocytes and monocytes, no, it is clinically significant as viral, tubercular, and fungal meningitis. Take note, viral, tubercular, and fungal meningitis, and it is also associated in what we call multiple sclerosis. Okay? Take note, guys, that multiple sclerosis is different from multiple myeloma. Okay? Next is we have neutrophils. Neutrophils is correlated or clinically significant with bacterial meningitis. Sometimes in early stages of viral, tubercular, and fungal meningitis, it is also increased. And aside from that, no, CSF that contains increased amount of neutrophils is clinically significant into a cerebral hemorrhage. Now for macrophages, that is RBC in spinal cord or spinal column rather, and contrast media. So RBs or macrophages are larger cells than our lymphocytes or our WBC. Now we have here blast. Blast is clinically significant into acute leukemias. No? And microscopic findings, lymphocytes, myeloblast, or monoblast. Now, for lymphoma, disseminated lymphoma is the lymphoma cells is the clinically significant to a disseminated lymphoma. For plasma cells, multiple sclerosis, lymphocyte reaction, and then we have epididymal, choroidal, and spindle-shaped cells that is correlated with diagnostic procedures. So, ibig sabihin, if you found epididymal, choroidal, or spindle cells, then it suggests that the sample is CSF. And malignant cells is correlated into metastatic carcinomas and primary CNS carcinomas. Okay, so these are just the illustrations of the cell constituents that can be found on our CSF cell count. Okay, in order for you to browse or to look or to see these pictures or illustrations, I encourage you to browse your book and to see a larger picture or a clear picture of these cells. Okay, so aside from hematological or cell count, we are also performing a chemistry test for our CSF, and one of those tests includes our CSF protein. Now, what do we mean or why do we need to count our CSF to obtain our CSF count? Take note, guys, that CSF is not CSF does not contains albumin. Okay, does not contains albumin. Why? Because our blood-brain barrier, diba, as we discussed, blood-brain barrier does not allow the passage of proteins. Now, this major protein albumin, as you see here, is seen kapag po yung mga pasyente natin ay mayroong damage in our blood-brain barrier. Now, the second most prevalent CSF or protein in the CSF is our prealbumin. Okay? So, ibig sabihin, increase in these proteins is suggest damage to the blood-brain barrier, and the damage in the blood-brain barrier suggests meningitis and hemorrhage conditions or hemorrhagic conditions. Now, let's say, for example, there is a decreased amount of CSF protein. That means that we have CSF leaking. Okay, so aside from that, we have our alpha globulins such as haptoglobulin and ceruloplasmin, which is our acute phase reactants. Correct. No? Next, we have our beta globulins, uh, beta 2 transferrin. Now, take note, guys, that the tau protein is the only protein that can be found in our CSF. Okay? Gamma globulins includes IgG and some are RGA. Now, take note, guys, that IgM is not seen in our CSF because of its pentameric structure, which does not allow us to pass into our blood-brain barrier. Fibrinogen is not also seen because our CSF does not contain fibrinogen as well as lipids. Okay? Now, in order to determine our CSF protein, we have two methods. We have the total protein, the turbidimetric, and the dye binding. For turbidimetric, we are going to use the trichloroacetic acid, and this is the preferred method. No? Because trichloroacetic acid precipitated both albumin and globulins. Aside from trichloroacetic acid, we have sulfosalicylic acid, which precipitates only albumin. And we need to add sodium phosphate or disodium phosphate just to precipitate albumin. So instead of adding disodium sulfate to precipitate globulins, might as well you need or we recommend to use trichloroacetic acid. Now, on the other hand, we have dye binding such as the Comasi Brilliant Blue, which allows protein binding to dye. The dye is red, and once the proteins bind with our dye, it will produce a blue color, which means intense blue color suggests increased amount of our proteins. Now, aside from this total proteins, we have also our protein fractions using our CSF serum albumin ratio and our IgG index. Now, our CSF serum albumin ratio assesses the integrity of our blood-brain barrier. Okay, as we know, our blood-brain barrier does not allow the passage of our albumin or our protein in our CSF. Now, if our CSF serum albumin index or ratio is less than or equal to 9, it means that we have a normal blood-brain barrier. And then, if our CSF serum albumin ratio is greater than 9, it suggests that there is a damage in our blood-brain barrier. And it should be correlated to the degree of the damage. And take note that if our CSF serum albumin index is greater than or equal to 100, it suggests that it has or we have a complete damage into our blood-brain barrier. And how are we going to compute for our CSF serum albumin? We have to use this formula, CSF albumin over serum albumin, as simple as that. Next in line is we have the IgG index. IgG index assesses the condition with IgG production within the central nervous system. Example of which is the multiple sclerosis. Okay? Now, normal value is less than 0.70 and greater than 0.70 indicates that there is an IgG in our central nervous system. And the formula is as follows: CSF IgG divided by serum IgG over or divided by CSF albumin index. Okay, so this is another chemistry test, which is our CSF electrophoresis. Okay, as we discussed in electrophoresis, we said that CSF can also be used in our agarose gel electrophoresis, and CSF electrophoresis should be done in conjunction with serum protein electrophoresis. What is the purpose of that? The purpose of that is for the detection of the oligoclonal bands or the abnormalities into our gamma region. Now, we have two or more oligoclonal bands in the CSF but not in the serum. No? This peak in the oligoclonal bands suggests multiple sclerosis. It suggests multiple sclerosis. And other conditions with oligoclonal bands includes neurosyphilis, encephalitis, neoplastic syndrome or disorders, as well as our Guillain-Barré syndrome. Okay? So, multiple sclerosis, take note guys that multiple sclerosis is a demyelinating disorder and the finding includes uh, positive for anti-myelin sheath, okay? Positive in oligoclonal bands in the CSF but not seen in the serum. Oligoclonal bands seen in the CSF electrophoresis but not seen in our serum electrophoresis. Positive also for myelin basic protein. Now, what do we mean by myelin basic protein? It means that a protein component of a lipid protein complex but or that insulate the nerve fiber. Okay, take note guys that the presence of myelin basic protein or MBP in the CSF suggests destruction of the myelin sheath. And take note guys that one of the most important thing to consider in the multiple sclerosis is increase in IgG index. Aside from that, we also have to perform CSF glucose. The purpose of performing the CSF glucose is to take note and to differentiate viral meningitis from other types of meningitis, because as we can see in this slide, it is only viral meningitis which accounts for a normal CSF glucose, while for tubercular, fungal, and bacterial, no, the CSF glucose is increased. Now, what is the condition or why do we have increase in bacterial meningitis or increase in CSF glucose, decrease in bacterial meningitis, tubercular meningitis, and fungal meningitis? The very reason on that is because bacteria, fungi, and tubercular, such as this Mycobacterium tuberculosis, utilizes glucose as their source of energy in the CSF. Now, take note guys that CSF glucose must be done in conjunction with our blood glucose. And take note po mga kapatid that no, our CSF glucose is 70% of our blood glucose. No? The CSF glucose, the normal level of our CSF glucose is almost 70% of the blood glucose, which means if our blood glucose is 100 no, mg per dl, therefore our CSF glucose is seen at 60 to 70 mg per dl or 65 mg per dl. Now, increase in CSF glucose is due to increase in plasma glucose. Now, take note that there is a inverse relationship between our glucose CSF and our lactate CSF. As you can see in this table, we said that CSF is decreased in cases of bacterial meningitis, tubercular meningitis, and fungal meningitis. But in our CSF our lactate is increased in cases of bacterial meningitis, tubercular meningitis, and fungal meningitis. Why? The very reason on that is because since our microorganisms utilizes our glucose as the sole source of energy, no, they synthesize glucose to lactic acid. That eventually will give us lactate as the product. That's why as the metabolism or as the synthesis of our glucose increases, therefore it will cause decrease in glucose CSF, and at the same time there is an inverse relationship of increase in our level of CSF lactate. And the same thing goes with viral meningitis. Since CSF glucose in viral meningitis is normal, therefore, it is expected that our CSF lactate is also normal in cases of viral meningitis. Now, as we have here, no, lactate is inversely proportional to our CSF glucose. Now, how about our CSF glutamine? Take note, guys, that CSF glutamine is a product, or glutamine, no, is a product of ammonia and alpha ketoglutarate, no, and indirect test for the presence of excess ammonia in our CSF. Now, take note, guys, if there is a presence of ammonia, no, it is, or glutamine, no, glutamine, since ammonia, no, the product of ammonia is glutamine. Therefore, increase in glutamine suggests disturbances of the consciousness, which leads into comatose, and increase in ammonia is seen in what we call race syndrome. Okay. Now, aside from that, we also have CSF enzymes, particularly the lactate dehydrogenase and our creatinine kinase. Now, take note, people, no? Sabi natin, lactate dehydrogenase is our least specific enzyme because it is widely distributed in the bloodstream. No? Siya yung pinaka-least specific natin na enzyme. And take note, guys, that in our serum or in our blood, lactate dehydrogenase, serum lactate dehydrogenase, LD2 is seen to be normal. LD2 is higher than LD1. If we are going to arrange the fractions of lactate dehydrogenase according to its level of, or according to its amount, no, LD2 comes first. So, ibig sabihin, si LD2 po yung mayroong pinakamataas na concentration of lactate dehydrogenase in our serum, to be followed by LD1, 3, and 4. Now, flip pattern is seen if there is what? Increase in LD1. Now, take note, guys, if there's a flip pattern, that is usually seen in nephrotic syndrome and in myocardial infarction. Now, for CSF lactate dehydrogenase, take note, in serum CSF lactate dehydrogenase, in serum lactate dehydrogenase, LD2 is higher than LD1. In CSF lactate dehydrogenase, LD1 is higher than LD2. And the flip pattern, no, and the flip pattern in our lactate dehydrogenase for our CSF suggests neurological abnormalities. Why? Because LD1 and LD2 of our LDH isoenzyme in CSF is specific for brain tissues. Take note, LD1 and LD2 of isoenzymes ng LDH lactate dehydrogenase is specific for brain tissues. That's why, if we have a flip pattern in the CSF lactate dehydrogenase, it suggests neurological abnormalities. Now, if in case that LD5 is higher than other LDH, no other isoenzymes of LDH, then it suggests bacterial meningitis. Aside from lactate dehydrogenase, we can also use creatinine kinase BB or simply our CKBB. No? And increase in CKBB is seen in post-cardiac arrest and in damages in our blood-brain barrier. Okay? Less than 17 nanograms per ml indicates recovery. Okay? So we have here the table that will differentiate us the diagnosis of our meningitis. So there are 4 basic types of meningitis: bacterial, viral, fungal, and tubercular meningitis. Now, we have also here the predominant cells for each types of meningitis. Well, definitely, we said that lymphocytes and monocytes are the predominant cells in our CSF. However, increased amounts of this suggest the possibility of having a meningitis. Increased amount of lymphocytes alone suggests viral meningitis. Increased amount of lymphocytes and monocytes suggest fungal meningitis or tubercular meningitis. Again, for protein, all meningitis or all types of meningitis suggest increased amount of protein. Why? Because there is a damage in the blood-brain barrier which allows the proteins to pass through our CSF. Next, glucose is normal in viral meningitis but decrease in our tubercular, fungal, and bacterial. For lactate, that is the opposite, no, of our glucose and remains normal with our viral meningitis. Now, the other information for bacterial meningitis, we have, well, definitely positive for gram stain, positive for culture, and positive for Limus lysate test, which will be discussed later. Okay. We also have the most common agents of bacterial meningitis, which will be seen or presented in the next slide or in the next slides. Okay. Next is we have viral meningitis. So we have here enterovirus as the common cause or the common infectious agent for viral meningitis. We have poliovirus, echovirus, and Coxsackie virus. Of these three, take note, of these three viruses, it is Coxsackie virus, which is the most common cause of viral meningitis. Well, for tubercular, the most common cause or the causative agent of tubercular meningitis is Mycobacterium tuberculosis. Again, a pellicle or web-like clot formation in our CSF suggests tubercular meningitis seen in patient with Mycobacterium tuberculosis in the CSF. Okay? While for fungal, Cryptococcus neoformans is the most common agent of fungal meningitis. It is positive in gram stain and under gram stain, fungal or fungus shows a gram-positive reaction, or in other words, it shows a starburst pattern. It is positive in India ink, which is an example of negative stain. Why negative stain? Because of instead of giving color to the cell itself, it gives color to the background. No? And fungal meningitis is also positive for immunologic test for Cryptococcus neoformans. Okay, so this is what we call the starburst pattern. Yan. This is the starburst pattern that appears gram-positive using gram stain. And this is our fungal cells. No? This is our Cryptococcus neoformans in our India ink black background. Clear cells suggest the presence of Cryptococcus neoformans. Okay? So Limulus lysate test, and this is a test in bacterial meningitis which detects gram-negative bacterial endotoxin in the body fluid and surgical instruments. And the reagent in Limulus lysate test is blood of the horseshoe crab. And the principle is the presence of the endotoxin. The amoebocyte will release protein, and the positive reaction is clotting or clot formation. Again, so here are the agents of the bacterial meningitis depending on the age group. So we have the birth to 1 month old, no, Streptococcus agalactiae and gram-negative rods. 1 month to 5 months old, Haemophilus influenzae. 5 years old to 29 years old, where we belong. The most common causative agent is Neisseria meningitis, meningitis pala, I'm sorry, meningitis. 29-year-old and above is Streptococcus pneumoniae. Infants, elderly, or immunocompromised, the most common cause is Listeria monocytogenes. Okay, so please take note of this, take note of the age group, and take note of the causative agents. Now we have serological test as what we have mentioned, no, latex agglutination test and ELISA for the detection of bacterial antigens, and VDRL. Now VDRL is recommended for neurosyphilis. Okay, so thank you for listening. I hope you learn and enjoy our discussion about CSF or cerebrospinal fluid. Thank you and God bless you all.